Good morning. I would like to start by thanking Dr. Shashi Kapoor for giving me the opportunity to be a part of this instruction course. Today, let's learn the approach to interpreting corneal topography and pachymetry. Corneal topography and pachymetry are the foundation for successful refractive surgery and a happy patient with a stable cornea. There are three techniques for determining corneal topography. The first and oldest is the Placido-based and began with the Placido disc, and was followed with the video keratoscope. The next is slit scanning systems utilized in the OBSCAN as a combination of slit scanning and Placido imaging. The third and the most popular used technique is the Scheimpflug imaging and is used in the Pentacam, the Sirius, and the Galilei. Modern topographers provide us with an overwhelming amount of information. It is easy to get lost in the maze created by all this information. Even the basic 4-map refractive display gives us the elevation maps for the interior and the posterior cornea, the corneal thickness, the interior curvature map, different data about the interior and posterior surface of the cornea, the corneal thickness displays, and anterior chamber data. It is important to enable us to browse and analyze this information in an efficient manner. And to do so, it is crucial to adopt a strategy. We'll start by first the basic, which is confirm the identity of the patient. It is very important to make sure that you are viewing the reports of the same patient that you intend to operate upon. Next, confirm the quality of the scan. In the quality specification, it specifies the quality of the data captured. It should be a white box with OK. Otherwise, there is some missing information which has been extrapolated by the machine and will be shown in a yellow or red box. In this case, the capture must be repeated. Next, we look at the pachymetry. The pupil center is the corneal thickness which corresponds to the center of the pupil, and its locations and coordinates are important to evaluate angle kappa. The pachy-apex represents the thickness at the apex of the cornea. The computer considers this as the origin of the coordinates. The thinnest location is the thickness and location of the thinnest point of the cornea. The difference between the thinnest location and the pachy-apex is normally less than 10 microns. The y-coordinate is most often normal when it is less than 0.5 millimeters, and suspicious when between 0.5 and 1 millimeter, and abnormal when it is more than 1 millimeter. Compared with ultrasound pachymetry, which measures thickness at only 1 point, the Pentacam can generate 50,000 data points to describe the true thickness. The normal pachymetry map has a concentric shape. Next, we look at Kmax. The maximum curvature diopter of the whole interior surface of the cornea expressed in diopters. A value below 47 is suitable for refractive surgery, while a value between 47 and 49 is a moderate risk factor. Next, we look at the Q value. The Q value is defined as the radial change from the center to the periphery of the cornea. It reflects the shape of the cornea, its optical properties, including the refractive power, the spherical aberration. Normal values range between -1 to 0. More than 0 would be seen, values less than 0 would be seen in late corneas, and less than -1 in hyperprolate corneas. Such corneas are at a risk of higher spherical aberrations. Next, we look at the interior curvature. The interior curvature map represents the interior surface dioptric power measured by the sagittal method. One normal pattern is the symmetric bow tie seen here. The flatter cornea appears in cooler colors, while the steeper cornea appears in warmer colors. We can see many different shapes over here. Normal shapes which do not predispose a patient to the risk of ectasia, such as round, oval, symmetric shapes, and at the same time asymmetric shapes and irregular shapes which have a very high risk of ectasia. It is important to choose the correct settings for displaying the colors in the curvature map. A 0.25 diopter step can lead to a lot of noise, while a 1 diopter step leads to a washout of all the details. A half diopter step has been suggested as the ideal value that represents all the information we need. Next, we look at elevation-based tomography. Now, while Placido imaging is useful in determining the surface corneal curvature, elevation tomography is what helps determine the overall corneal shape and the spatial thickness profile. In order to make elevation data clinically useful, it is displayed against a non-planar reference surface. A reference surface, which is typically a sphere, is constructed by fitting the reference surface as smooth as possible to the data surface. the best fit sphere. To help us understand this, what a best fit sphere is basically doing is changing the x-axis on a graph that is representing all the data. Over here, if we change the x-axis to this, it's much easier for us to help understand what this data means. It is then clinically useful for us. Elevation maps, which are normal, will show a symmetric hourglass pattern. We can see abnormal patterns such as tongue-like extensions or irregular patterns. The color scale for elevation maps will be green if it is matching the reference best fit sphere, red if it is anterior to the best fit sphere, and blue if it is posterior to the best fit sphere. Normal values less than plus 12 microns will display as green. Suspicious areas between plus 13 to 15 microns will be yellow, and areas that are more elevated than 15 microns will appear in red. In the posterior surface, again, anything up to 17 microns is displayed in green, anything between 18 to 20 microns is displayed as suspicious, and more than 20 microns is red. In keratoconus, we will see an island of elevation both posteriorly and anteriorly. We can also use differential maps, which help us to track stability of the patient over time by allowing us to compare two scans simultaneously on one screen. Next, we look at the Bell-Ambrosio deviation index, the BAD display. In the Bell-Ambrosio BAD display, what we see is first we have the two standard elevation maps, which display the baseline relative information of the cornea with the best fit sphere. Next, below them are the anterior and posterior exclusion maps. These are enhanced elevation maps which display elevation data with the best fit sphere recalculated using all the raw elevation data, which is outside a 4 millimeter circle, which is centered on the thinnest point of the cornea. The difference elevation map shows us the difference between the normal best fit sphere and the optimized best fit sphere. Areas that are normal with a difference of less than 5 microns will be displayed in green. Areas that are suspicious between 5 to 7 will be yellow, and areas that are highly suspicious will be more than 7 microns and displayed in red. The D value that is displayed has 5 components. We have the DF for the front surface, the DB for the back surface, the DP for the pachymetric progression, DT for the thinnest point, DA for the thinnest point displacement. The final D parameter, which represents the overall reading of all the 5 parameters, is performing a regression analysis against a standard database of normal and keratoconic eyes. Normal values of up to 1.6 are suitable for refractive surgery. Suspicious values between 1.6 and 2.6 will appear as a yellow box, and it is ideal to first reconfirm the data by performing the scan once again, and then decide if the data is accurate or not. Patients who have values more than 2.6 and are displayed as a red box are abnormal. The thickness profiles that are displayed will be the corneal thickness spatial profile, which describes the average progression of thickness starting from the thinnest location to the corneal periphery. The percentage thickness increase describes the percentage of progression of the CTSP. The red line is the data of the examined cornea, while the black dashed lines represent the double standard deviation of the corneal thickness. A normal profile will follow the shape of the black dotted lines while not necessarily conforming within them. Now, ectatic corneas thin more rapidly as you progress from the center to the periphery. So these curves help us differentiate between a normal thin cornea and from one with early ectatic disease. Normal values for thickness profiles are between 0.8 and 1.1. Thickness profiles more than 1.1 are suggestive of ectatic disorders, while thickness profiles less than 0.8 can be seen in edematous corneas or sometimes in pellucid marginal degeneration. A quick slope like this, where the red curve leaves its course before the 6 millimeter zone, is very suggestive of either keratoconus or ectatic disorders. Similarly, with an S-shaped curve. The Ambrosio relational thickness values, the ART values, it is a ratio of the thinnest pachymetry and the pachymetric progression indexes at different meridian. A value more than 400 is very safe for refractive surgery, while values less than 400 are very suspicious. Let's come to a few cases. The first case, so we'll start off by identity. Next, we come to the quality, which in this case is okay. Then we come to the pachymetry, where at the center of the cornea, it's 566. The thinnest point is 562. Both are normal. The difference between the two is less than 10 microns, and even the Y location is less than 0.50. The Q value in this case is minus 0.39, which is optimal. The anterior surface curvature appears normal with a symmetric bow tie. The K max is 44.9. The interior elevation, all values are within the normal range. The posterior elevation also the same. The bad display also is only 0.54. That would be a suitable case for refractive surgery. Next, we come to a case, again, the quality, the specification is okay. The pachymetry values are 465, thin is 433, not suitable for refractive surgery. Although the QS value in this case is within the normal range. The interior curvature shows a claw shape. The K max is 48.6. The interior elevation is plus 28. The posterior elevation is plus 47. The bad display is 7.41. Definitely not suitable for refractive surgery and should be considered for keratoconus. Another case like this, where we can see, again, the quality specification appears okay. The pachymetry all appears within normal. The Q value is also normal. But the anterior curvature shows a symmetric bow tie, but just against the rule. Again, the K max over here is 47, which is borderline. Anterior elevation is plus 3. The posterior elevation displays an irregular pattern. The ART max value is less than 330, is less than 400. Again, very suspicious. The PTI average also is 1.2. This is a patient where ideally you should repeat the scan, and if the data is similar, you should counsel the patient that he's at a higher risk of ectasia. Coming to pachymetry. There are two basic techniques for pachymetry, which will be optical pachymetry or ultrasound pachymetry. We have the Scheimpflug, the slit scanning, and AIOC and specular microscopy in optical pachymetry. Studies have shown that all of them have a high correlation, though low interchangeability. And for most cases, whatever machine you're using for a topography is the same that you'll also use to obtain your pachymetry values. To end, it's very important to measure twice and cut once. Most cases who will present with ectasia will be cases that were borderline on topography but were missed in the preoperative evaluation. It is very important to repeat the test wherever you have any, even a low index of suspicion. Confirm before you proceed.